Let's go to the next slide. This is an important one, which shows the kind of drugs which can actually cause hyponatremia. So if your patient comes in with a hyponatremia, you need to look at the medications they take. The common culprits are obviously the diuretics, thiazide and indapamide, loop diuretics, tricyclic antidepressants, and in anti-epileptics, carbamazepine can cause low sodium levels. These drugs act by different ways. You can see that they either potentiate the action of ADH, the carbamazepine, or they cause production of excess ADH. So you remember our patient who is still in ED, her condition is getting better, she's more conscious, alert. So we were waiting for her blood results. It came back showing a serum osmolality of 250, urine osmolality of 500, and urine sodium of 56. So what would be the diagnosis? So we take a moment to pause the video and think about the diagnosis. All right, I hope you got the answers correct. This is syndrome of inappropriate ADH. As the name suggests, this is inappropriate or excess ADH production causing the syndrome. And these are the common causes of syndrome of inappropriate ADH. You either have a brain injury, sometimes meningitis, lung infections, malignancy, especially small cell lung cancers, pneumonia, tuberculosis, cerebral abscess, low thyroid, hypothyroidism in extreme forms, all can cause excess production of ADH, thereby leading to SIADH. And although there's a malignancy part, can be a chronic problem in patients with this as ADH producing paraneoplastic tumors. So it will be difficult, a challenging situation to treat those patients. So usually you diagnose ADH by clinical examination, making sure the patient is euvolemic, and then go through the biochemical tests, which are showing a serum osmolality less than 275, and inappropriately the urine osmolality is more than 100. They remains euvolemic. They have a lot of sodium excretion in their urine, and they have a normal thyroid, adrenal, and cardiac functions. So if they meet all these criteria, like our patient, they have got a diagnosis of syndrome of inappropriate ADH. So the usual treatment for syndrome of inappropriate ADH is fluid restriction, because they have excess fluid in their body. So you restrict their fluid, so thereby try to improve the sodium levels. But these are the factors which will tell us if the fluid restriction might not be working very well. If they have urine volume less than 1.5 liters, if they have already got very concentrated urine, and the first equation, which I'll come to the next slide, more than 1, all will predict the failure rate of a fluid restriction. So it might not work always, but it's always worth giving it a try. First equation is actually you calculate, you already got the urine sodium, you add potassium to it, urine potassium, and divide it by serum sodium. And you can see that from this ratio, if it is less than 0.5, you need to restrict to 1 liter, less than 1 liter, and between 0.5 and 1, you need to restrict less than 500. And if the first equation is more than 1, it's very unlikely they will benefit from fluid restriction. So they might need other treatment, which are the medical treatment. So we have 2 different medications which we can use for SIADH management. One is demyclocycline. As you know, it is a tetracycline antibiotic. It kind of produces a nephrogenic diabetes insipidus, thereby getting rid of excess fluid in the body and helps to improve the sodium. That is one of the treatment which we used to do a lot, but nowadays it says it has got very limited evidence. It has got severe toxicity, so it may not be an appropriate treatment in all the patients. So Then we have got vaptans, which are V2 receptor antagonists. So you remember the collection duct, which has got vasopressin receptors. So this antagonizes the V2 receptors, thereby helping to get rid of excess water in the body. Usually it is licensed up to 30 days of use, but it needs quite close monitoring. You usually give a 15 milligrams or even 7.5 milligrams and see the response. If you make a clinical diagnosis of SIADH and the patient's sodium is not improving and they are symptomatic, you might need to try that. Or in cancer patients where the curative intent may not be possible, so they might continue to produce the ADH from paraneoplastic tumors. So it's kind of helping you to correct that. So whenever somebody is on vaptan, tolvaptan or conivaptan, you need to relax their fluid restriction, allow to drink them according to their thirst, and they need quite frequent monitoring to make sure they are not overcorrecting. Of course, at this stage, you might need to consider referring to your local endocrinologist or asking their opinion about this treatment. So out of this, the rate of correction for sodium, so usually it is accepted that if they have a patient who has got high risk of overcorrecting, it's up to 6 millimoles per 24 hours. And if it is a low risk, it's 8 millimoles and not more than 18 millimoles in 48 hours. All right. So coming back to our patient, so you corrected her, given her hypertonic saline, probably you might have given some vaptan just for argument's sake, and you find out the next day her sodium is 124 to 105 before, so it's corrected in 24 hours by 90. So what is the risk in overcorrecting the sodium? So we'll go through that in the next few slides. So this is a problem when you overcorrect sodium. This is called the osmotic demyelination. So this is used to be called as CPM, central pontine myelinolysis, but since we changed the name depending on the CNS findings on autopsy results and MRI findings, now it's better called osmotic demyelination. So as you can see in this diagram, so if you keep a cell in a hypertonic saline solution, it just shrinks. So it just disrupts its cell membranes and get damaged. That is what is happening in osmotic demyelination when you correct the sodium too rapidly. So usually we think, why brain? Why no other organ? It's mainly because the brain is contained within a skull, a closed cavity called the skull. So there is not much room for the brain to expand or change according to the osmolality changes and the correction of sodium. So it's a very vulnerable organ for getting the complications. But not all patients are at risk of developing hyponatremia overcorrection symptoms, but we have to be careful. But these are the patients who are at high risk. So if you have a patient who is got chronic alcohol excess history, malnutrition, or prolonged diuretic use, or liver failure, or previous history of liver transplant, any organ transplant, excessive burns, and also hypokalemia, this is seen to be associated with osmotic demyelination risk, and also they have a very high risk if their initial sodium was less than 105, or the risk is also high if their sodium was less than 120. Seldom happens when the sodium levels are above 120, but still we have to be careful in monitoring these patients. So what are the symptoms you get? So you get kind of CNS symptoms, you develop dysarthria, dysphagia, get altered mental status, quadric paralysis. This is called the locked-in syndrome, whereby your body is paralyzed below your neck, so it's kind of locked in. And these symptoms might not immediately develop. There may be a lag period for a week or so, and even MRI initially won't show any symptoms, any signs at all. So it might be a delayed presentation. So usually patient might even be discharged, go home and develop these symptoms there, then come back and then we do another MRI which shows these changes in the central nervous system. Unfortunately, it is quite often irreversible damage and quite often goes to medical legal problems. So it will be worth closely monitoring this patient's progress. So we'll see how to prevent and how to treat this. So prevention, as you know, prevention is monitoring hyponatremia carefully, making sure it's not going above 6 millimoles in high-risk patients or not more than 8 millimoles in low-risk patients within 24 hours, not more than 80. Suppose if you happen to have overcorrected, what you can do? So you can reverse the overcorrection by giving some hypotonic fluid, usually 5% dextrose. You can also give desmopressin or DDAVP, thereby to retain as much as water as possible, thereby preventing further increase in the sodium. So these are the things you can do. There are still good evidence that if you reverse the correction rate quickly enough, you can prevent or even reverse the progression of the osmotic demyelination syndrome. Unfortunately, recovery is quite variable depending on how was the initial sodium, how much damage has happened to the brain. So we are almost coming to the end of my presentation. So we'll just go through a few things about hyponatremia in other situations like cirrhosis and CCF. In this condition, we can develop cirrhosis, hyponatremia and cirrhosis and CCF. But in this situation, the hyponatremia indicates the severity of the underlying pathology rather than a pathology of its own. So there are quite a few studies which indicates that hyponatremia in these patients carries increased morbidity and mortality. It is often due to secondary hyperaldosteronism caused by the severe chronic hypervolemic state. And these patients, we try to avoid overcorrection. Could be careful diuretic use. You can fluid restrict them. You treat the underlying heart failure, liver failure, cirrhosis. And once the underlying conditions get better, their sodium levels improve. So these patients often pose serious challenges to the treating team. Their sodium is low. They have multiple other issues happening. So it's worth looking at them as a holistic way to find out what things we can do and be careful not to overcorrect it. So in this talk today, I talked briefly about the hyponatremia, the clinical and the biochemical assessments of hyponatremia. Talked about hypertonic saline, different strengths, and when to use it, and what is true hyponatremia, that is hypotonic hyponatremia. What's the importance of urine sodium, when it is going to be low, when it is going to be high, and what is SIADH, how you can calculate osmolality bedside, how you can assess SIADH patient, and if you correct at all, how to monitor them carefully to avoid osmotic demyelination syndrome and thereby preventing complications. So thanks for listening to me. I'll come up with more videos in the future about other endocrine topics. And if you like this video, please post some comments about your questions. I will try to answer as many as possible and try to share it with your friends. Thanks so much. Bye.